I'm Angry Bill, and this is Prehospital Wisdom. I had the opportunity to change my mind recently. Actually, it's been going on throughout my career, so let me tell you about this. I give a lot of analgesics to a lot of patients, like a lot. Back in the day, like decades ago, I used to be much more stingy. In the first agency I worked for in the mid to late 90s, documenting and restocking opiates was a monumental hassle. In addition, during the formative stages of my career, physicians were pretty stingy with orders. We had to make base contact back then, and it wasn't uncommon to get an order for 2 milligrams of morphine. An EMS adage holds, severe pain plus 2 milligrams of morphine equals severe pain. I think that's a medical adage, not just an EMS adage. So it worked out that a patient needed to have a large BSA second-degree burns for me to go through the hassle of opioid administration. I'm not trying to make excuses for poor care. I'm just explaining how I used to do things. Times change, and that's the whole point. So over time, analgesia changed. First, modern EMS practices and protocols make it very easy to administer narcotic and analgesics. There's essentially no cost to me in time or effort. In addition, over the past decade or so, protocols have relaxed to the point of being able to give reasonable doses of medications. Fentanyl was added. Also, I realized a couple of things. EMS rule number 1 says to make people better than how you found them. Concentrating on helping people as the metric of your success makes your job more mentally and emotionally enjoyable. Don't concentrate on difficult ALS calls or wild, rare procedures as your metric of success. Just concentrate on helping patients. One of the easiest ways to help a patient is to give them pain medications when they're in pain. I believe patients when they say that they're hurting. There's no cost to me to give some seeker some medications. There's no cost to me to give meds to a patient who isn't in real pain. After all, who am I to say what's real pain and what isn't? I don't care if my patient's a sissy. Who am I to decide if pain is severe enough to warrant fentanyl? I don't care if their vital signs don't reflect numbers that I expect for a patient in pain. If a patient says they're in pain, I offer analgesia. Within reason, of course. I'm still a good clinician. If they accept it, I give it. It's a simple way to chalk a call up in my win column, and I've been doing this for several years without problems. But times are changing again. Now there are many more options for analgesia in my armamentarium. How's that for a word? Armamentarium. Yeah. Anyway, NSAIDs are much more common now, and I've been having really good effects from Toradol and acetaminophen. So my practice will be changing again. I'm honestly excited about that. Fewer opioids, but similar pain relief is a good thing. Bring on the NSAIDs. Here's another example. I rarely give antiemetics like ondansetron or droperidol, especially in comparison to many paramedics. The protocols I grew up with indicated those medications for intractable vomiting. Essentially, if I couldn't provide care over the noise of someone screaming for their friend Ralph, I would give them medications that would allow me to do my job. Those protocols changed at some point where they now indicate antiemetics for nausea. Not intractable vomiting, just nausea. A couple of weeks ago, I told a trainee to hold off on giving Zofran to a patient. The patient complained of nausea, but I wanted to see at least a little retch before treating the nausea. Come on, give me a wet-sounding burp at least. It wasn't like the patient was puking or even had been puking. Their vital signs were normal and everything. Dude's stomach was just a little bit queasy. On my way home, thinking about that call, I found myself experiencing cognitive dissonance. If it makes sense to give analgesics more freely, based solely on a patient's report of their subjective pain, why doesn't the same logic apply to antiemetics? The answer that I came up with is an obvious one. The same logic does apply. I realized that withholding antiemetics is stupid, at least as stupid as not giving analgesics for complaints of pain. All my reasons for administering analgesia work for administering antiemetics too. The protocol allows it, there's minimal cost to me, the medications are relatively safe, and they're easy to deliver. I can give the meds via IM injection. I don't even need to start an IV. Why wouldn't I get an easy win? Why wouldn't I help a patient and make them feel better? If making someone feel better is a win, why wouldn't a good paramedic give the medication that makes the patient feel better? So now I'm trying to offer antiemetics a little bit more. I still try and wave an alcohol prep under a patient's nose and other less invasive ways to end nausea first, but a little IM Zofran is an easy thing to do. What's your threshold for antiemetics? Let me know down in the comments. If you found any value at all to this video, please click the like and subscribe. One of the most helpful things you can do is share this content with someone you know. Click over here for another video, or click over here on this side for the channel page and all videos. Subscribe's a button down somewhere below, and I'm trying to hit 1,000 subscribers, so I could use your help. I'm Angry Bill. This is Pre-Hospital Wisdom. Until next time, stay safe.